Hello, and welcome to Conversations with Dr. Kohli. The world of diabetes and obesity management has recently been revolutionized with the advent of the GLP-1 receptor agonists. In fact, it now feels like they've become such a mainstay of treatment of cardiometabolic disease and cardiovascular risk reduction that we as clinicians often reach for them first. But what about the other medications out there, medications such as icosapentaethyl or IPE? How do they fit into this ever-changing landscape? And do we still reach for these medications as secondary prevention drugs? So to help me discuss icosapentaethyl in the modern era, I'm delighted to welcome Dr. Chuck Vega. Dr. Vega is a clinical professor of family medicine and the director of the UCI program for medical education for the Latino community. He's also an assistant dean for culture and community education at UC Irvine School of Medicine. Welcome, Chuck. It's a pleasure to have you.
Well, thanks for the very nice introduction, Pyle. Pleasure to be here.
So, Chuck, I want to dive right in because we're both clinicians, and I really want the clinicians today to take away some key pearls about where does icosapentaethyl fit in this spectrum of all the other preventive drugs that we have out there. Specifically, I want to talk about GLP-1 receptor agonists, because I know for myself, when I have a patient with diabetes and elevated triglycerides, or perhaps even a secondary prevention patient who's had cardiovascular disease, I tend to go upstream. I tend to focus on the cardiometabolic disease and the diabetes and start them on a GLP-1. So when would I think about starting icosapentaethyl, and how do you approach that in your patients?
Right. Such a great question. And, I'm about to actually complete 30 years now at UCI as a physician. I include residency training because I still see a patient from the second week of my intern year, believe it or not.
Oh my goodness.
Same clinic, same safety net clinic in Santa Ana. And so it's really remarkable to go from an era of where metformin was a hot new drug, and we were using a lot of insulin and sulfonylureas. Statins were these rare creatures that we couldn't touch, and they seemed magical. And now that's all part of our practice, and especially in the last 5 years, we've just really accelerated forward with many better treatment options and really thinking holistically about cardio, renal, hepatic, metabolic disease, because they all flow into one another and they all promote risks. And unfortunately, I see a primarily Latino, older patient population, diabetes, obesity, hypertension, hyperlipidemia, rampant throughout. So I don't feel like when I'm first seeing these patients, you don't have to hit every one of those themes and all of those new medications. But I'm really trying to steer patients onto, say, GLP-1s as a first line agent when available for their diabetes. But I'm also thinking about cardiovascular and renal prevention. Similarly, I'm going to steer them on. I'm a big statin hawk pile. I think you are too. I'm a big believer in trying to drive the risk down associated, particularly with LDL, with statin therapy, and that's so I'm using a lot of high intensity statins. Yet so many patients, a significant proportion, never get there in terms of triglycerides and reducing that attendant risk. And so there's where IPE can fit in as well. So I've always believed in continuity. I believe very much as well in going at the patient's pace. And so to flood them with like, hey, here's 10 new prescriptions, that's not going to work because of side effects and just feeling unsure about things. But introducing them two at a time, maybe, and then in a couple months, here's another two changes I want to make, and being strategic about it. 6 months later, it looks like a very different profile. Numbers look better, patients feel better, and I know for certain their risk is reduced.
I think my approach is very much the same, Chuck. I would probably start with that GLP-1, especially in those diabetic patients. And then if the trigs remain elevated, then clearly something else is going on. There's a parallel pathway. That's when I think about icosapentaethyl. And I really love what you said about taking a step back and actually looking at cardiovascular kidney metabolic syndrome, CKM syndrome, where we're now no longer internists or primary care doctors or cardiologists. We're actually total bodyologists. We're treating all the different systems and the way that they interact together. And I love that AHA paradigm of the CKM syndrome staging, just like we stage cancer. That makes us really, really sort of wake up and think about their whole overall cardiometabolic risk. So, I've used many of the same medicines, and it's nice to have the privilege to have so many medicines, because I think that's
the big difference.
Yes. Exactly. So I want to talk a little bit about the Reduce-IT trial, because as you know, that was the parent trial for icosapent and they had sort of two patient phenotypes in there: secondary prevention patients that had already had
Sure.
an event, and then patients with diabetes who hadn't had an event, but both types of patients had elevated triglycerides, almost as a biomarker of risk, so to speak. There was a subgroup analysis from that trial looking at the patients that had metabolic syndrome without diabetes. And I'm curious, what did the results of that subgroup analysis show?
So generally speaking, I think the other really important facet, you did a great job of summarizing Reduce It, which was a really remarkable trial. Very well done. These patients were already treated with a statin as well. So it's not like we were talking about using IPE to replace statin. Statins are really quite foundational. That LDL lowering therapy is foundational, but they still have that high triglyceride level. And the interesting thing is whether the patients had metabolic syndrome or diabetes, or they had pre-existing cardiovascular disease, IPE demonstrate a benefit, a significant benefit, not just in terms of necessarily as a minor outcome. We're talking about major outcomes of cardiovascular events, revascularization, things that really make a difference in people's lives, both in terms of longevity and in terms of morbidity as well. And so really you can see that there's many patients who have this residual hypertriglyceridemia, either with multiple cardiovascular risk factors or they have existing cardiovascular disease. And icosapent ethyl has been demonstrated to make a big difference for them.
Yeah, and metabolic syndrome is taking center stage again. And I feel like especially now with the GLPs and other drugs even showing a reduction in some of the non-alcoholic steatosis that occurs in
Mhm.
fatty liver, that's occurring metabolic syndrome associated fatty liver disease, or MAFLD as it is now called. We've really started thinking about metabolic syndrome almost as a distinct disease phenotype now, which I think before we had just sort of lumped it in with diabetes and cardiovascular risk and what have you. So, it's nice to be able to have all these drugs, but I am also somebody who likes to follow the guidelines. And so, have the guidelines kept up in terms of updating what they're recommending? I know that for diabetics, they do recommend a combined approach with GLPs and SGLT2s to sort of,
Sure.
treat them regardless of the A1C, based on their kind of risk profiles, whether they have kidney disease that's concomitant, whether they have risk for heart failure. But what do the guidelines say about how we should use icosapent ethyl with GLPs? Does one replace the other? Should they be used together? Or how do you think about that?
I think it's just worth taking a moment to say that not everybody can achieve this great combination. I agree. Using incretin-based therapy, a GLP-1 receptor agonist, or a GLP-1 GIP is effective therapy. Combined with SGLT2, really ideal. But many patients might not be able to get there due to reasons of cost. You've got insurance constraints, and so it's different. But I really want to strive for that. And if you can get one or not the other, that's still better than nothing at all. And so I would encourage clinicians and patients not to give up. And I do see these agents becoming more and more readily available. Icosapent ethyl is similar. So I do think it's very complementary. I see the value in terms of those patients so many times with metabolic syndrome. We can't get their triglycerides to goal with just lifestyle and statin therapy. IPE could be a really good addition for those patients. And I think it works very well with GLP-1s. GLP-1s don't necessarily have a direct effect, but losing weight, one of the first metabolic consequences is you start to see triglycerides fall, which is an outstanding result for so many patients. I know that over time that yields good outcomes.
Yeah, I mean, you made some great points there that they really are working in sort of parallel mechanisms. And there's so much going on with incretin hormones in the gut, even changes in, the microbiome of the gut, as well as how much inflammation is created in the gut, that I think we still have a lot to unravel there. But what I found really interesting about GLPs and icosapent ethyl is that they both modulate cardiovascular disease differently. So atherosclerotic plaque is actually different with the two different medications that changes in a different way. And of course, we know they both have outcomes data. They reduce major adverse cardiovascular events, but it's different. So talk to me a little bit about how GLP-1s change plaque versus icosapent ethyl. And does that make you think of them also as more complementary therapies rather than one replacing the other?
So you want the family doctor now to tell you, the
About plaque.
cardiologist, about
That's
plaque reduction.
right.
Okay, well, fill in the gaps for me. But yeah, you're right. They do work in different ways. And in terms of, really what we want to see is regression of existing plaque. So many people during middle age already have plaque in their coronary arteries, in their carotids, and we can test for that and then find it. With GLP-1s, we don't have as much data in terms of regression of plaque, but they certainly have mechanisms that go beyond weight loss. They create less inflammation within the vasculature. They have antioxidant properties. But if you look at the evaporate study specifically, looking at IPE, that was a study that involved folks who did have existing plaque where there was evidence of regression. And certainly there was much less progression with IPE versus placebo in that study. So again, I think we're thinking about complementary mechanisms, and together you should have synergy rather than an independent effect, one versus the other.
You made such great points. The GLP-1s in the SELECT trial, where you use semaglutide in patients who had obesity, no diabetes, but had cardiovascular events, secondary prevention population, you saw those curves diverge within a few weeks before they had even lost all that weight. And so there is so much more going on, more than just weight loss. And based on the STOP trial where we looked at plaque, we actually saw that it stabilizes plaque. So, we often think about plaque almost in two elementary a fashion. Is it there? Is it not there? What degree blockage is it? But it's so much more sophisticated than that. And, I would rather have an 80% socked in, stabilized, stable plaque in my Prox LAD than a 20% angry with a thin fibrous cap and a necrotic core type of plaque. So really what I have loved doing as a cardiologist is changing the plaque, is changing the trajectory of the disease using these types of medications. And as you pointed out, Chuck, in the evaporate trial, we did see both regression of plaque, but also stabilization as well with icosapent ethyl. So different effects of plaque with these two medicines. So Chuck, this has been such a scintillating conversation. I know that for me as a preventive cardiologist, it's been a good problem to have. We start to think about these parallel pathways of risk with atherosclerosis, obviously LDL first, and as you mentioned with statins, but then we've got inflammation, we've got obesity, metabolic syndrome, we've got thrombosis, we've got triglycerides, we've got lipoprotein A, which we didn't touch on today, but so many other pathways at play here that we really need to start as clinicians working on all those pathways. So any last words, Chuck, before I let you go back to clinic?
Well, no, I appreciate it. That was a great summary. And I feel like with all these new opportunities, it can feel a little bit overwhelming too. And I think one of the key questions is, well, who's going to prescribe these therapies? These therapies are not only effective, they're generally very well tolerated and safe. So I would say that they're very much in the primary care sphere. They're also in the specialist sphere. So if you're the one who sees the issue and you look at it and you talk to patients, you do shared decision making, you reason out that I want to start IPA, I want to start incretin therapy, then you're the person to start it. Importantly, though, if they're seeing cardiology, nephrology, try to communicate that. Make sure the patient's aware, make sure they get an updated list of their medications that they're going to take to all their specialist appointments. So communicate it across the healthcare team. And that way we don't have clinical inertia where we're just standing back. Well, maybe I thought the other person was going to do it. Unfortunately, that can yield bad outcomes, particularly when it goes on for months and months. I really dislike it. So be the one who's proactive and make these choices with your patients, and they're going to be better for it.
It's such a great point, and you saying it in a positive way with clinical inertia. But for me, it's often kicking the can. You say, oh, somebody else can deal with the prior auth, and oh, the cards can do it. Oh, the endo can do it. Oh, the primary care can do it. And sometimes as a primary care, I'm really glad you said this because they may feel intimidated or feel uncomfortable overstepping the specialist, so to speak. But I want to say as a specialist, I love when my primaries contact me and they say, hi, how about this? Or have you thought about this? And again, I'm also juggling so many balls, so it's possible I haven't thought about it. And I feel really, really good about it when they reach out. So as we blur those borders between cardiovascular, kidney, and metabolic syndrome, I think your point of blurring the borders of communication and just having an open line is such an important point.
Yeah, absolutely. It can all be done electronically. So certainly, yeah, I'd love curb citing too on controversial points. A lot of these are just kind of a question of working with your patients as to what's the right one to add on next and when, and then building from there, and then checking labs, etc. Following, making sure that the medications are having their desired effects. But in doing so, I feel like I've really, like I said, especially the past 5 years, really advanced patients' care forward. I think they're going to be healthier for a longer time, which is the whole point.
Yeah, and it helps us communicate, get off of our island. So we better care for patients.
Yeah.
Like we're happier as providers. So great.
Yeah.
Well, I want to thank you again for your insights. This has been a great conversation. I know that I'm taking away a lot. And I certainly hope that our audience takes away a lot as well. We want to thank you for joining us on Conversations with Dr. Kohli. And we hope that you'll think about all these different risk reducing pathways when it comes to your patients, because empowering yourself with actually making an impact in that patient's cardiovascular morbidity and mortality, that's the ultimate satisfaction in medicine. And that's why we all went into medicine in the first place, is to make that impact. So be sure to do that. And until next time, thanks, Chuck.
Thank y'all. Bye-bye.
Bye.